Well, I am Dr. Shannon Clark
Cool.
with Babies After 35 and also with the Dr. Delivers podcast. Today, I am going to discuss a very much anticipated, a very much needed topic with Dr. Kristin Lasseter. She is a reproductive psychiatrist with the Reproductive Psychiatry Clinic of Austin in Austin, Texas. And I want to, there's so much, and I actually put an Instagram post asking about questions, and the questions are excellent, but there's no way we can cover everything. So what I want to focus on today is specifically medications, psychiatric medications during pregnancy for those who either are on them preconceptionally and then are planning to get pregnant, or they happen to find out they're pregnant while they're on medications, or they need to start them while pregnant. So we can come back at another time and talk about breastfeeding while undergoing infertility treatment and things like that. We just don't, I want to dedicate the time specifically today to pregnancy. Is that okay with you?
Yeah, that sounds great.
Okay. And reproductive psychiatrist, explain to those that are listening, what exactly does that mean?
So basically, it is a psychiatrist who specializes in mental illness related to changes in reproductive hormones. So changes with estrogen, progesterone, around your menstrual cycle, of course, when you get pregnant, postpartum, menopause, all those fun times that we get to experience.
So to get to do reproductive psychiatry, you go through the years of residency training in psychiatry, and then do you subspecialize?
You can. So you can do a fellowship in reproductive psychiatry, or they have like women's mental health fellowships, or you can get extra training while you're in residency and do specialized like tracks of women's mental health, so that you can go about it different ways.
And then how could someone go about finding someone that does specifically what you do? And, so psychiatry is great and all that, but if someone's looking specifically for someone that does what you do, the reproductive psychiatry, how can they go about finding someone in their area that does exactly what you do?
So with reproductive psychiatry, I think it's a little bit hard. There's not like one main place where you can look up and find a reproductive psychiatrist, but with perinatal psychiatrists, so psychiatrists who specifically specialize in pregnancy and postpartum, you can go to Postpartum Support International's website, and they have a directory where you can look up at, psychiatrists who specialize in specifically pregnancy and postpartum. And then there's lots of other websites or directories that are out there. I can't name them all, but that one's probably the biggest and most well-known one.
Yeah, and I was just talking about that site with someone the other day. So it is a very helpful site to give you information to find, certain people that specialize more in those that need treatment, therapy, medications around pregnancy, preconception, postpartum. So that's a good place to start as Postpartum Support International. So why are we talking about psychiatric medications in pregnancy? And I'll tell you why I want to talk about it. Number one, it's hard to find good psychiatric care in pregnancy, no matter where you are. I am personally, as a maternal fetal medicine specialist, I am over having patients being told by any number of healthcare providers that once they get that positive pregnancy test, you need to stop all of your psychiatric medications, as if whatever they were on the medications for is going to magically go away once they're pregnant, or they're no longer in need of treatment. Now, I get that they're thinking about the fetus. That's why they're telling them to stop the medications and the what ifs with the medications. So what I was doing is that, I'm sure you see all the time and hear all the time that patients are told as soon as they get that positive pregnancy test to stop whatever medications they're on because of the what ifs for the pregnancy and the fetal effects, and without much consideration for what about the effects of stopping the medications on the pregnant person. So if for someone that's in that boat and is being told early on, before they get a chance to either see their psychiatrist or they're calling to make that initial prenatal visit, what would you recommend those persons doing? I would say as an MFM to not just stop everything, but what is the right thing to do in those initial few weeks until you can see someone such as yourself or someone like myself to get the medications squared away?
Well, Okay, I feel like this question's a little bit difficult because,
Mm-hmm.
you always want to listen to your own.
Mm-hmm.
And obviously I don't know everyone's history as well as their own doctor does, but I think even if you're thinking about the fetus, what's best for the fetus, I think it's important to remember that the illness itself is
Mm-hmm.
actually more risky for the fetus than most of the medications that we prescribe for mental illnesses.
Mm-hmm.
So taking, pretty much most antidepressants that we've studied, we have not found that they're more risky for the fetus or for the pregnancy
Mm-hmm.
than the illness itself. And so I would highly recommend that somebody maybe look up resources on really good websites. So not just Google or any website
Mm-hmm.
out there, but like women's mental health.org, looking up information on mothertobaby.org. Those are two really great resources that actually give evidence-based information on these medications in pregnancy and seeing, okay, what does this say? Does this say I absolutely should stop this medication, or does this say this needs to be a conversation? And then maybe waiting till you can talk with someone who specializes in this. Also, Postpartum Support International has a psychiatric consult line. So your OB-GYN or your psychiatrist can call the PSI line and say, hey, I want a second opinion, or my patient wants a second opinion on them staying on this medication during the pregnancy. Should they stop it right now? Or, what should be the next steps? And they're great at giving you expert advice from people who are specifically trained in this area.
Yeah, I think it's just good to make the point that there's two patients. You have the fetus and you have the pregnant individual, and you can't sacrifice one for the other. I understand everyone's need and desire to protect the fetus at all costs, but I've seen as a maternal fetal medicine specialist so many times where the patient was advised stop everything, and within a few months they're in such a bad situation, which is not good for the pregnancy either. And we will talk about that as well. Untreated mental health disorders, whether it be depression, anxiety, bipolar disorder, anything like that, can have, just as Dr. Lasseter said, a severe consequence on the pregnancy itself and cause adverse pregnancy outcomes. So, I guess probably when you see someone that's in the reproductive age category that may not be considering pregnancy, you have a little bit more leeway as far as what medications you can give them. But if you are someone who's starting to contemplate pregnancy and you are on medications, would you suggest having a conversation then with whoever's prescribing those medications and managing them? Hey, I'm thinking about potentially starting to become pregnant. What should we do now as far as changing up the meds, or the meds that I'm on? Okay, when should that conversation occur?
I feel like that conversation should occur when any medication is started, to be honest. And I know that would never happen. But because I think, what is it, like 50% of pregnancies are unplanned. So, so most of the time people aren't going to actually have the luxury to plan out, okay, what medication should I be on? What should I not be on? What's better for me or for the baby? So I think whenever you're starting a medication, having that conversation with somebody who is of reproductive age. But yeah, obviously, if you can have it, the sooner, the better. Yeah. So giving yourself like a year or two to plan ahead of time. Okay, should we try other medications? And then giving those medications ample time to see if they work or not, to see if they're going to keep you stable or not is important.
It's important. Yeah, I think, and I think as an MFM, what I want to stop doing is making pregnant individuals feel like or think that they have to stop everything, and if they need to be on the medication, that they're not being good for their pregnancy or their fetus, or they're causing harm. Because it's with anything. It's not just mental health disorders. It's with anything that we take in pregnancy. It's a risk-benefit analysis. Giving someone insulin, giving someone medications for seizure disorder. So keeping the stigma on mental health disorders and the medications that are needed to treat mental health disorders and pregnancy, that needs to stop. Because it's no different than any other medical condition in pregnancy, and we need to treat it as such. So why do you think there's still such a stigma around medications and those that need treatment during pregnancy for mental health disorders?
Gosh, I wish I knew the answer to that question.
I mean, because you and I, it doesn't make sense to us, but I mean,
yeah. I mean, I think part of it, it's definitely a cultural thing, but I think, even in our own medical training, I mean, I don't know how it was for you, but for me, like mental health, that training portion of medical school was still kind of, oh, this isn't as important, and this isn't as medical as, treating pancreatitis or, and so I think the brain is just such a complicated organ that people are like, I don't really know much about that, so we're just going to say it's, pseudoscience or whatever, instead of, recognizing we just don't know enough about it yet.
And it has to be treated just like hypertension, diabetes, lupus, anything else in pregnancy. But I also think there's a component too, for certain providers, of liability. Well, if I keep them on this medication and something happens to the fetus, but there's also liability that if you take the patient off the medication and something happens to the patient. So it's not, we can't always put the fetus first. And I know sometimes it's hard for them to hear that, but if we don't have a healthy pregnant individual who's making the fetus, we're not going to have a healthy fetus. And if that means being on medications, then that's what it means. And the same thing I would say, when I tell a diabetic, I don't want to put you on insulin because I'm just not sure. So just deal with your diabetes and your high sugars. No, because high sugars are just as toxic to a developing fetus. So there's no difference. So I hope we're making that point across anyone that's listening. It's no different than any other medical condition in pregnancy and needs to be treated as such. So hopefully this will help to destigmatize that a little bit, because I do still feel that it's still there, even amongst healthcare professionals, and we've got to stop that. You touched on a little bit about some of the adverse. Okay, you back? Can you hear me? Yeah. Okay. So you touched a little bit on. I don't know what it is. She keeps freezing. I'm sorry. What can you do? Okay. So let's talk about a little bit about the consequences of untreated anxiety, depression, bipolar disorder, schizophrenia, those types of the main categories of psychiatric illness or in pregnancy. What are some of the consequences on the pregnancy itself if those disorders go unchecked, untreated?
So the common ones are preeclampsia, baby being small for gestational age, premature birth or preterm birth, and then of course baby getting, having to go to the NICU. Those are the big ones. More and more research is coming out showing that there's actually like structural brain changes that happen in the fetus that then predispose the baby to having mental illness later on in life or having behavioral issues as a young child. And so we see that their stress response as babies is actually different from babies who weren't exposed to mental illness in pregnancy.
Okay, so there are consequences of untreated mental health disorders in pregnancy, and we have to consider that when deciding as an individual and as the physician-patient duo when or if to stop medications, and also when to start them. So are there any general treatment principles? I know that, for example, you want to be on the lowest effective dose. Rather than being on multiple medications, try to get it down to the one or two that might control the symptoms the best. That's in an ideal situation. Are there any other general principles of treatment that are ideal in pregnancy?
Yeah, so ideally trying to minimize exposure, right? And mental illness being an exposure itself. So you don't want to give somebody medication and have them on this low dose that's only partially treating their symptoms, because then baby's getting exposed to the medication, but baby's also getting exposed to the mental illness. So making sure that really it is an effective dose that you're on. And a lot of times that means then it has to be higher than they would have been taking pre-pregnancy, because as we all know, you get a lot more fluid in pregnancy, you're metabolizing things a lot differently, so that includes your medications. But yeah, so minimizing the number of exposures, And that includes what was baby exposed to in the very beginning of the pregnancy. So was mom on, you know, X antidepressant when she got pregnant? Do you really want to switch that antidepressant and risk then exposing the baby to 2 different antidepressants? Because now you're going to switch it to a different medication. And maybe you're also increasing the baby's risk of being exposed to mental illness because maybe that second antidepressant doesn't work as well as the one that she was on. So really trying to stay whatever has kept the mom well the best is usually what you want to stay on, with all things considered.
Exactly. And then this was one question that I got on the Instagram post, and I hear this all the time from healthcare professionals too. Let's just stop it for the first trimester and then restart in the second or third trimester. Is there any benefit at all to doing something like that?
No, not really. If the medication has really large concerns of causing birth defects, then maybe. But as far as psychiatric medications go, the only one that has a really big risk of doing that is Valproic Acid, which they shouldn't be on for the pregnancy anyways. Even later on, it increases other risks. So really, there's no medication that there's a reason to do that with for psychiatric meds.
Yeah, I mean, a lapse in treatment is a lapse in treatment no matter what it's for. Am I going to tell my patient has a seizure disorder, let's just stop? Unless it's something that's, you know, there are a couple of anti-seizure meds that actually are treated for, that can treat some psychiatric disorders or mental health disorders in pregnancy as well, but say for seizure disorder itself, that you don't want someone to be on, and you will tell them and you have to switch them over. But for the most part, am I just going to say, let's just hope you don't seize in the first trimester, you know, and cross our fingers? No, I mean, a seizure in pregnancy is not a good thing. So, you know, the same principles apply to if you have bipolar disorder, depression, anxiety, untreated, any of those is going to have the same potential same consequence. So let's jump to just to talk a little bit about depression. Most of the data from what, you know, and I've done a little bit of reading, psychiatry, you know, I am very quick to consult psychiatry on my pregnant patients when needed, because I want them to get the best care. Am I a specialist that can kind of do global care on my pregnant patients? Absolutely. But psychiatry is not one of those things that I'm just going to gamble with. I need input from psychiatrists because that's what they do and that's their expertise. But I understand that probably the most data for antidepressants is going to be from the SSRIs. Is that fair to say?
Yeah.
And then some of the more common ones would be what, Paxil or paroxetine, sertraline or Zoloft. Lexapro is one of the more newer ones, correct?
Lexipro's older.
Oh, it's older. Okay. But is it used as much? Because I don't see patients on it as much. Yes, it still is.
Yeah, we have a lot of data on pretty much Lexapro, Celexa, Prozac.
Yes.
And
what about
Paxil? We have good data.
Luvox
we don't have good data on.
Yeah. So those
Hybrid, we don't.
Those are the main ones that I had listed here, and the ones that I probably see the most are going to be the sertraline or Zoloft, Lexapro, and Celexa. I don't see as much Prozac anymore, but it could just be the general prescribing practices where I'm at. Overall, for SSRIs in pregnancy, what does the data show about, you know, as far as the safety regarding birth defects? Are there any particular SSRIs that we have more of a concern about having a specific birth defect with?
So in older studies, there were concerns with Paxil and Prozac. Newer studies have actually shown that that's not an increased risk with those medications. So as far as the ones that we have a lot of research on with SSRIs in pregnancy, none of them have shown to increase the risk of any birth defects.
Okay. And so obviously staying on treatment, if you're on any of the ones we just mentioned, and did I miss any common SSRIs that are prescribed in pregnancy, or are those the most common ones that we mentioned?
Tricyclic is another one.
Okay.
It's another SSRI, but it's not, we don't have a lot of research on that in pregnancy.
Okay.
So but no, you didn't miss.
I'll just go recap it real quick. The Paxil, Zoloft, Lexapro, Luvox, Celexa, and Prozac. Now, from what
Luvox, I don't think we have a ton of research on.
Okay. So, you know, probably Celexa, Zoloft. Are those the most common ones you see? Prozac in
Celexa,
pregnancy?
Zoloft, Prozac, and Lexapro are the most common.
Yeah. So when you consider a risk of a birth defect versus a risk of untreated illness or depression, I think it's pretty clear that the risk of untreated depression probably outweighs what could potentially happen if there's a birth defect. Now, there's not great data that's going to say 100% sure on pretty much any medication we give in pregnancy that there's no risk for any kind of effect on the fetus in the first trimester. We're not saying that. But what we're saying is when you put the two together, a risk of a birth defect versus a risk of untreated illness, we're starting to get to where we need to keep that illness treated as opposed to worry about the birth defects. Now, a lot of things that we hear about is this neonatal withdrawal syndrome or neonatal adaptation syndrome. Is there a difference between the two when it comes to, so it's just different terminology for the same thing?
Yeah, we actually don't have, that was one of the things. I was at a conference this weekend with the Marseille of North America, and they talked about, still an update with that is that we don't really have a great outline of what is this thing, what is it specifically called, neonatal adaptation syndrome or withdrawal syndrome, and then what are the exact symptoms. It's not really defined well. So yeah, I usually call it neonatal adaptation syndrome because I feel like withdrawal kind of gives this stigmatizing.
Yeah, and I'm starting to see that more as well. But it can happen, and that's probably one of the reasons I see also, this is another question, do I stop my medications in the third trimester to prevent that from happening? Because some providers are telling their patients to do that.
Which makes me so mad.
Me too.
I'm just going to say makes me so upset.
I wasn't trying to trick you because I'm completely 100% on board with you. I'm just like,
yeah,
yes.
I know. No, okay, so neonatal adaptation syndrome is time limited, right? So the baby, if they have it, so most babies don't have it. If they do, it's going to be, about a week, and then they get over it. There's no long-term effects from it. Versus stopping the medication in the third trimester, you're significantly increasing the risk for mom to get mental illness again. Let's say she gets sick, depressed, or anxious again. Then those are going to have long-term consequences on the baby. Maybe mom then she's at increased risk of getting postpartum depression or postpartum anxiety, and that's even worse for the baby. So I feel like if we're our whole goal is to think about what's best for the baby, even though these medications cause neonatal adaptation syndrome, or increase the risk in some babies, it's still safer for the baby than exposing them to the risk of the mental illness.
Yeah, and that's why, the pediatricians are going to ask what you were exposed to, and you say, I've been on Zoloft my entire pregnancy, or I've been on Prozac. They're going to be watching out for that and being notified that there is a possibility and, be on high alert and surveilling the kid for any kind of signs of neonatal adaptation syndrome. I've seen it so many times where my patients were told, stop once you hit 28 weeks, stop once you hit 32 weeks, and their postpartum period is hell because maybe they did decide to go back on, but now they're behind the 8 ball, if you will, and it's too late, and then they get really, really sick, and then infant bonding is an issue. Being able to take care of the newborn is an issue. Being able to take care of yourself is an issue, and it's a lot of catching up to do. And sometimes I just had a patient recently that it's in a really bad situation because that is what happened. So we have to, and I'm not trying to scare anybody. I'm not saying it's going to happen with everyone, but it's something to consider, right? We're not trying to say if you stop in the third trimester, you're going, no, but it is a possibility, right?
Yeah, I mean, I think it's important to point out that pregnancy is not protective against mental illness.
Right.
That used to be a thought that they used to teach people back in the old days.
Yeah.
It's not true. Pregnancy is actually an increased risk for mental illness, and postpartum, especially those first 3 months postpartum is when people are most vulnerable to have a relapse.
Right. So I think that if you're the takeaway is if you're on a treatment for your depression in pregnancy and you've been doing well, you've been managed, just keep going and stay par for the course, stay with your medication. And then sometimes even if you've been on a certain dose in the postpartum period, you might need to change that a little bit. That's why we increase the surveillance a little bit in the postpartum period. But just to keep those things in mind, because the physiology of pregnancy and the postpartum period change. and can change how your medication is distributed, eliminated, all those different things. And so your dosage might need to change. So those are things to consider as well. So let's jump a little bit to the tricyclic antidepressants. How common are those now for being prescribed for depression and pregnancy? And what do we know about those as far as their effects in pregnancy?
So those are definitely less common.
Yeah.
We don't have a ton of research on them compared to like the SSRIs that we have, but overall the research, for them as a class seems to be that they're safer to take in a pregnancy than, to take someone off of them and risk mental illness from showing up again. There's not any evidence showing that they increase the risk of birth defects or increase the risk of complications in the pregnancy specifically. And, again, I don't think there's a ton of research showing that they increase the risk for neonatal adaptation syndrome, but, I think that would be something you'd want to watch for.
Right.
Anyways.
Yeah, there's not a whole lot there, but it is something that is to be considered, just like with the SSRIs. But there's not as much information on the TCAs or tricyclic antidepressants as there are on the SSRIs. And then if you jump down to the atypical antidepressants like bupropion, duloxetine, you probably know these better than I do, venlafaxine. I don't see those as much. Again, it could be due to the prescribing practices in my specific area, but are those not as prescribed as commonly as the SSRIs?
They're not prescribed. So SSRIs are usually first line treatment for depression and anxiety. So I think for that reason, they're, studied a lot more.
Yeah.
But yeah, like bupropion, it does have some research in it.
Yeah.
There's some concern that maybe it has an increased risk of, I think, heart defects, but that's been really wishy-washy in the literature. And it's a great medication for preventing people from relapsing with smoking. So it's another thing that it's used for. So, and then Effexor or venlafaxine and duloxetine. There's fair amount of research on those in pregnancy. And I personally, if somebody came to me and said, hey, this is what's kept me well for the longest, and this is what's worked the best, I wouldn't feel uncomfortable with them continuing that in pregnancy.
Right. Okay. So yeah, and I have been seeing more Effexor. I definitely see more bupropion because of the smoking population in in our area that they do come in pregnancy having been on that. Kind of as a dual effect, both if they have depression and if they're trying to stop smoking as well. So sometimes docs will have them on that. Anything else you want to add about, we're going to jump next to bipolar disorder. Anything else you want to add about the depression and antidepressants in pregnancy?
I will say one that I see prescribed a lot is buspirone. So I see that prescribed a lot by people who aren't psychiatrists. So maybe people who are OB-GYNs or primary care doctors. But we don't actually have a lot of research on that one in pregnancy. And so if it hasn't been particularly helpful for people, then, I think that's one that they could hopefully, switch for something else or just stop taking. And usually that one's prescribed with another antidepressant. Okay. So optimizing the other one that they're on instead would probably be
ideal. Okay.
Be the ideal.
Okay, so let's talk about bipolar disorder. First, we're going to talk about the mood stabilizing drugs, which the most common one would be lithium. And what do we say, or what do we know about lithium in pregnancy?
So lithium has a very small increased risk of Epstein's anomaly, which is, I think, compared to the general population, the risk when you take lithium is, I can't remember the exact numbers, but it's so tiny that, do you have the numbers in front of you?
So the initial studies said there was a 400-fold increased risk. Now that's since been disputed. So let's see, more recently, 1.2 to 7.7 as far as a risk ratio. So it's probably somewhere in between. And then the latest one might be for overall any kind of malformation of the heart, be 1.5 to 3, which is a little bit increased, but not over what the general background risk would be for anyone getting some kind of congenital heart defect. So I think it's safe to say there's probably a slightly increased risk of something like Epstein's anomaly or another type of heart defect, but not exorbitantly above what the background risk is in the general population for heart defects.
Yeah. And I think that they found that using, I think doses less than 900 milligrams decreases that risk some in that first, while the heart's being developed in those first, 8 weeks or whatever. And then also, folic acid, taking folic acid, I think has shown in some studies to decrease the risk for that with lithium in particular.
Yeah, so that is true. There's not really a recommendation on how much. If you're considering something like Valproic acid, and we'll talk about that, you're going to want to be taking about 4 milligrams. But I think for lithium, anywhere between 1 and 4, especially through the first trimester, is ideal. But there's really no study that says 1 is better than 4. So it kind of is just physician dependent. When you talk about lithium is one of the more mood stabilizing drugs that is a little bit more prone to changes as due to the physiological changes of pregnancy, as far as the dosage might need to be changed more frequently during the course of the pregnancy, right?
Yeah, so usually people check a level like in each trimester, but it as early as like 8 weeks, I think it can start changing in terms of the level. And I haven't had a patient who the level has not changed, so it's normal that you'd have to increase the medication throughout the pregnancy as kind of your blood volume changes and your renal filtration changes too. So how much you're excreting the medication.
Yeah. So lithium is one of those things that you want to make sure your OBGYN and your psychiatrist are working as a team together on, ideally with any medication that you're on, but that's not always going to happen. Let's be realistic. But for something like lithium that does need to be monitored a little bit more closely, it's very important that a team approach occurs between the psychiatrist and the maternal fetal medicine specialist or OBGYN, so that we can make sure we measure those levels and adjust the lithium dosage as needed and throughout the pregnancy. I've seen a couple patients fall through the cracks on that, and then they end up not being on a high enough dose and can start to have breakthrough symptoms, and then that can become problematic. So it's very important that we really monitor that. Are there any other certain types of treatment guidelines that you need to consider once you have a pregnant patient, other than what we just talked about, that's on lithium? Anything else to consider?
So a lot of times they'll want to monitor the baby when baby's born too, because they can't. There are some babies who end up getting lithium, having too much lithium in their body, and so they'll have some side effects from that. Again, there hasn't been shown to be any long-term consequences from that. But yeah, just monitoring the baby throughout the pregnancy too.
Okay. And generally, if someone entered the pregnancy on lithium, is it generally better to just stay on it or switch to something, another type of antipsychotic? What I've seen is that they generally, if they're being managed well pre-pregnancy, that you kind of want to keep them on it. Is that right?
Yes. So the kind of the leading experts in bipolar disorder and pregnancy throughout the world say that you should stay on, for most patients, if lithium's has worked the best, they should stay on lithium rather than switching to a second generation antipsychotic or a different type of mood stabilizer. Because we don't, with second generation antipsychotics in particular, we don't really have great research and a lot of evidence on their safety in pregnancy. We're still learning about those. Whereas lithium, it's been around a long time. And so if that's what's worked the best for the mom, then that's what she should stay on.
Yeah. And from an MFM perspective, that's generally what we do as well. And again, I'm not going to manage lithium. That's out of my wheelhouse. I'm going to make sure that I know and have a direct line of communication with the patient psychiatrist so that we can work together. I think one of the things that we shouldn't do as the obstetrical care providers is wing it when it comes to these types of medications, and that we have to have that team approach with the psychiatrist, and so that we're doing the best thing we can for the patient. And I've seen that happen as well. And I'll just refill your prescription without really the necessary surveillance that needs to be done throughout the pregnancy. And we need to do more than that. It's not just a matter of refilling the prescription. Somebody had asked as far as antipsychotics about Latuda. I'm not as familiar with that. What do we know about Latuda or lurasidone?
So it's interesting. Latuda actually gets prescribed frequently in pregnancy by some people because it is classified for some reason. And back when they used to use
the ABCD,
those FDA, it was classified as a B for no good reason. I mean, just because we don't have a lot of research on it. So I think some people still use those classifications, and so it gets used for that, but it's actually, there's not a lot of great research on it. We do have more research on Seroquel, Zyprexa, Abilify, and Risperdal. Those are probably, and Haldol. Those are probably the ones that we have the most amount of research on in pregnancy.
Okay, so if something needs to be switched up, those are the ones to look for. But again, I think one thing I always ask is, what have you been on in the past? What's worked for you in the past? I don't necessarily, for the certain things that I feel comfortable treating, I just don't want to start with something new. I ask them, and as someone that has a history is going to know, I tried this before and it didn't work. I tried this before, but this I did pretty well on. So that's a good starting place. And the same thing can be said for those with bipolar disorder. Most of them are going to know what they've been on in the past that worked and didn't work for them. So the conversation needs to be had. As far as using anticonvulsants for the treatment of bipolar disorder in pregnancy, most of the studies are done not on those with bipolar disorder, but those with seizure disorder. So it's a little bit tricky because are the results due to the underlying seizure disorder of any studies that are done, or is it because of the medication? That can be said for anything that you're studying, any drug for any medical condition. Is it due to the underlying results of the medical condition being studied, or is it the medication? That's sometimes very hard to tease out in pregnancy. But most of the data we have, especially on Valproic or Valporic Acid, Carbamazepine, lamotrigine, are going to be done in studies of women with seizure disorder. So let's talk first about lamotrigine or Lamictal. What do we know about that medication as far as an anticonvulsant for the treatment of bipolar disorder in pregnancy?
So that one is probably, if I had to pick one medication for bipolar disorder, then I feel most comfortable with using in pregnancy, it would be that one. Let's say that one's the one that has worked the best for the mom, then that's best for me too. So that one we have pretty good research on now. We keep getting more and more research on it, and the more that comes out, the better it looks. And it doesn't, seem to have any increased risk of congenital malformations. There doesn't seem to be major risks on the pregnancy. Doesn't seem to have issues, kind of withdrawal symptoms or anything like that in baby once baby's born. So it really seems to out of the medications be the safest one if we're going to isolate it. But again, the safest one is whatever's worked the best for mom.
Right. And then Valproic acid, we touched on that a little bit earlier. That is associated with an increased risk of congenital malformations, specifically neural tube defects, that will require a higher dose of folic acid. Obviously, if someone's been on it and they're out of the first trimester, the neural tube's already been formed, and we will need to do some additional ultrasounds to take a look at the fetal spine and the brain, if we didn't stop the medication in time. But generally, what are the recommendations regarding valproic acid in pregnancy?
Generally, that's one of the red flag ones. That's honestly, for me, one of the only ones that I don't feel comfortable with continuing in pregnancy, and may even risk, okay, let's try something that you haven't tried before. Just because we do know that it increases the risk of malformations. It does increase the risk of the baby having long-term issues in terms of development and IQ. But, if that's the only thing that has kept mom well, then having an alive, healthy mom is much more important. But that's a tough one. That's
it is tough.
I kind of think it shouldn't be used in women of reproductive age in general, unless it's absolutely needed. There's not another option.
And we're getting more and more options to try as well. I remember back when I was training, we didn't have a lot of options. So that's what we had to use. But we're getting different types of medications that we can try. But I agree, because of the up to 50% of unplanned pregnancies, and most people don't realize they're pregnant until after the neural tube is even formed. So if you're on Valproic Acid during that period, and before you even got to that pregnancy test or realized, the neural tube's already been formed. So that would be another reason to not use that, unless obviously that's the only thing that is working and that's what the patient responds the best to. We would not withhold that from that individual. And just appropriate counseling and just making sure the patient's aware. And then carbamazepine would be another anticonvulsant that's used for the treatment of bipolar disorder. And what do we know about that?
That one, actually, I'm not up to date on carbamazepine. I did just listen to a lecture about that one, and I think I may have zoned out.
So
yeah, talking about
so
that
there's,
one.
but well, it's okay to zone out because there's not a whole lot. It's kind of it's kind of right now, as of now, put into the same category as Valproic Acid. Why is it? Because we don't have enough information, probably. But based on what we know and the potential that's there, it's kind of considered, those two together, that out of all the medications, those two would be avoided if possible. And if you can't, same thing, folic acid, additional folic acid is going to be needed. And if there's nothing else that manages the patient and that's what they respond to the best, then that's what we treat them with the understanding that we need to do additional fetal surveillance as far as ultrasounds go to look for certain congenital defects that may happen. But yeah, don't worry about zoning out on that, because again, I looked it up, and even what ACOG says, there's still not a whole lot there, and so it is what it is.
Yeah, the research is not great on that one.
It's not, but we'll get there eventually. Let's jump to anxiety disorders. I get a lot of questions about the benzodiazepines for the treatment of anxiety disorders. What say you? I see Xanax. I see Klonopin a lot. Those are, I put down the most common. Those are probably the two most common ones that I see. First, are there any other ones that are used more commonly in pregnancy? And then generally, what do we know about the benzos in pregnancy?
I'd say Xanax, Ativan, and Klonopin. Yeah, those are probably the ones that I see the most. Well, so I feel like I'm a little bit biased about benzos because I don't like benzos. And I'll see patients who have been put on them for anxiety, and they're taking them, multiple times a day, every single day. And they really, in terms of long-term use, have a lot of evidence that they increase the risk of dementia and just aren't good for your brain long-term. So I have a little bit of a bias against them. But in terms of their use appropriately in pregnancy, so mom's having panic attacks, or she's having really severe anxiety and can't function, and you need that to kind of help bridge her till her other medication's working better. It's, there's not really a lot of research saying that they're bad in pregnancy. There used to be some research saying that they might increase the risk of cleft lip and cleft palate, but that's been pretty much disproven. As long as they're taking them kind of as needed in the second and third trimester, there's really not much risk that's been shown there. I think when women are taking them every single day, multiple times a day, then that's when we get a little bit more concerned for the baby, especially, when baby comes out and has withdrawal symptoms from it.
Yeah, and I would agree with that, because so much happens in pregnancy, and benzos can be taken multiple times a day. And if I see a patient that's escalating how much and is not getting simultaneous treatment, whether it's with therapy, then I start to become concerned that maybe they're relying on the medication, and not that they're doing it purposefully. It's just that things change. Pregnancy is not easy. The benzos do work. And if you're taking them up to 4 to 6 times a day, it's easy just to escalate that dose. So we, as providers, if we have patients that are on them, they need to be taken only when needed. If you notice that there's starting to be an escalation, what I've seen a lot, and they're going through their scripts quicker, then we need to, ideally they should already be seeing a therapist or a psychiatrist. But if they're not, then they really need to, because it could be that they just need to start getting through that therapy, and they don't really need the medications. And again, I don't think that they're doing it on purpose. It's just because it's there, and they know they can take it multiple times a day, they need to. Is that your general experience? Have you seen that happen?
Yeah. I mean, they're a type of medication that we automatically build tolerance to.
Yes.
And so you over time will need more and more of it if you're taking it. You know, they act on the same receptors in the brain that alcohol does. So it's just like, you know, having a glass of margarita every, you know, 4 hours or something. And I say that because, you know, our other psychiatric medications, a lot of them, like our SSRIs or like lithium or mood stabilizers, what they're doing in the brain is actually helping to heal the brain. So they're initializing things that are going on to help our neurons form better synapses with each other, to just kind of help cure the illness or help actually make things better from a biological level, whereas benzodiazepines are more just like a band-aid. They're not necessarily improving things on a more biochemical level.
And I also would think, and I've seen this a lot in my patients too, they have anxiety disorder, but without really understanding, is it real anxiety disorder, or are they having anxiety because of past trauma, PTSD, having had sexual trauma in the past, which can invoke anxiety. And so we need to know, especially with anxiety disorder, what is is there any underlying diagnosis that we're missing, and we're just treating it as anxiety disorder and letting that kind of not be treated and addressed. So whenever I see a patient that has anxiety disorder, I want to know, how did you get diagnosed? Who diagnosed you? What was going on, you know, that caused this? Because, you know, sometimes other things kind of led up to that. Am I making sense? I'm not a psychiatrist, I know what you do, but that's what I've seen.
No, that's exactly right. Yeah.
And so, you know, and that's with any psychiatric disorder in pregnancy, but particularly with anxiety, I see that more. There's a lot of underlying things that happened in the past, childhood trauma, anything else that it has led to having a lot of anxiety, and then they'd come in having been on benzos without ever addressing what caused it to begin with. So I think as an OBGYN, do we want to sit down and open that Pandora's box? Probably not, but we might need to. We might need to, because it's hard to tell a patient, you know, you need to stop taking your benzos, or you need to cut back if that's what they've been relying on. So we have to look at the whole picture there. Somebody had asked the treatment of acute anxiety attacks. Somebody has anxiety disorder, then they have an acute anxiety attack, or is it the same thing as a panic attack? Is that interchangeable?
I think for most people it is. I mean, technically, clinically, it's called a panic attack. And there's a very specific, you know, criteria and stuff for it, but I think people use those interchangeably.
And then, so how would that be managed, or would it be managed any differently?
So if somebody's having panic attacks regularly, or they're having them, you know, somewhat frequently, then it's usually recommended that they do therapy, or they start on like an SSRI type medication to help the underlying anxiety that's going on, that's triggering these panic attacks, and then taking a benzodiazepine when the panic attack happens, if it's, you know, lasting a long time and is really impairing, or using like meditation or breathing exercises. Those can be just as helpful for some people.
Yeah. So, and every individual is going to be different as far as how that's best managed. But what I don't recommend is, especially someone that has anxiety, a history of panic disorder or anxiety disorder and panic attacks, is just waiting until it happens. I don't want to take anything. And again, cross your fingers and hope that you don't have that panic attack. And then the next thing you know, you're in labor and delivery because you're in a full-blown panic attack. You know, just be on the maintenance medication to try to prevent that from happening. Because people that have really severe panic attacks in an acute episode, that could be very problematic in pregnancy and hard to treat. And then you end up getting a bunch more things to treat it that you probably could have avoided if we had just managed, you know, had you on something all along. And I see that a lot with patients who want to avoid taking anything. And I get it. You know, I've been pregnant. I know you don't want to expose the baby to anything that you don't have to, but you have to think about the consequences of not taking it, and what is that, you know, having serial panic attacks going to do to the pregnancy. And I've seen that as well. Have you seen that too?
I've seen that. And it's, you know, there's even research to show like panic attacks and high anxiety in pregnancy. And it's just, you know, it's not good for the baby and for the pregnancy. And
I mean, I've even had patients come in that I thought were having severe preeclampsia because their blood pressures were so high, but it really was just a bad panic attack. And they're two very different things, right? And, you know, a severe preeclamptic with severe ranging blood pressures could need delivery, whereas a panic attack and your work, you know, the blood pressure can be high because of that. It's different. So, you know, just if you have a history of having anxiety disorder and a history of panic attacks, just get on the medication that keeps you stable throughout to try to avoid those intermittent, really full-blown panic attacks. Would that be your recommendation as well?
Yeah, I mean, I think for some people, I think they can manage it with therapy too.
And yes, therapy.
Similarly with depression. Yeah. But yeah, it would be, you know, finding the treatment that has worked for you and doing that in pregnancy, because a lot of times those anxiety disorders, just like depressive disorders, get worse postpartum too. And that's a time when they can relapse in those.
And since you brought it up, this conversation is about medications in pregnancy. I'm not saying medications without therapy. I truly that should go hand in hand. So that we're just talking specifically about certain medications, but I'm not saying that we'll just take this medication and avoid therapy. Absolutely not. We still need to be making sure our patients are in therapy of some sort, in you know, concert with the medications. The last thing one of the things I want to talk about is schizophrenia. Now, you know, that's not, I don't see that as much in pregnancy. I see patients more infrequently than the other ones we just talked about. What are the general medications and management principles for someone who has a history of schizophrenia or schizophrenia and they're pregnant?
So in general, it's again keeping them whatever has kept them well. So for most people with schizophrenia who are functioning well and functioning, you know, living life in a normal way, a lot of them are on long-acting injectable medications, or they have been on whatever they've been on since, you know, their early 20s or their teens when they first got diagnosed. And so don't change those medications, just stay on them. And for a lot of people that is a long-acting injectable. And so sometimes we use that in pregnancy as well.
Yeah. And that's generally what we see. That's not a time to experiment with medications. With someone with a diagnosis of schizophrenia, whichever's working for them is what we want to keep them on, obviously hand in hand with the person that's been managing them. It's truly a team effort, and you want to make sure that there's direct lines of communication between both providers or both specialties. Actually, I lied. There's one other one, and actually, this is the most popular question. Treatment of ADHD and stimulants in pregnancy. Once upon a time, it was a huge, big no-no. You cannot take stimulants in pregnancy. You know, even if you had narcolepsy, and I have a friend who has it and has been on stimulants because she genuinely has it, wants to become pregnant, and she was like, I can't come off of it. You know, there's no way. Things are a little bit better now. We have a little bit more information. So what's the general knowledge about treating ADHD with the different medications in pregnancy?
So we are getting more research on this too. It's those medications we probably have the least amount of research on, I would say, because, you know, in the past it was more just looking at people who had abused methamphetamines or stimulants. And now we're actually looking at, okay, what about women who are taking them at appropriate doses in pregnancy? What happens with those pregnancies and those babies? And for like Adderall in particular, which one is one that's amphetamine that's prescribed a lot, you know, we don't see many increased risks with taking that medication when it's taken at appropriate doses. And a lot of times women don't even need to take it every day. They can kind of take it as needed when they have work or whatever stuff that they need to do. But it was interesting. A study was done, I can't remember where it was now, where they found that women who stopped their stimulants, who had a diagnosis of ADHD, stopped their stimulants, they actually saw that those women had higher depression scores in pregnancy than women who continued their stimulants, even if they never had a history of depression before. And the thought was kind of like, well, you know, they have ADHD, this medication is used to treat ADHD so that they can be more functional. You take away that thing that's been helping them be more functional, and they don't feel as adequate or feel like they can handle things is better, and that makes sense. So I think it's really weighing like how important is this medication to treatment for you? How do you do without the medication? You know, are you still able to function and you know, are you still able to take care of your other kids if you're stopping your stimulant medication and you have ADHD? And can you do that safely too? So really making sure that you're kind of weighing the risks and benefits. With the other ones like 5-ANTS, lisdexamfetamine, and Concerta, Ritalin, dextroamphetamines, you know, we just don't have, I think, as much information about them. And one of them, you know, there's some research that maybe it increases the risk of congenital heart defects. It's kind of, you know, still there's just not great amount of information out there.
Yeah, I mean, I think just studying any kind of medication in pregnancy is hard. As we have seen with the whole vaccine and then COVID vaccine, but it's anything. If you look to any medications being studied in pregnant individuals, most of the prescribing practices are done on non-pregnant females and males. We have a long way to go. It's getting better for studying appropriately medications in pregnancy. One of the things I try to get my patients to do is there's always registries for taking medications where you can sign up, and I'll put that in the caption. That is still something that people can do, right? Say that they're on some kind of stimulant. And what we mean by this is that there are registries you could sign up for if you're on any of these medications we talked about, where they can track you, you can give your information and see what your pregnancy outcomes. And that's how they can get some data as well, as through these registries. And it's actually can be very beneficial to get more information. It's kind of like what I used to do with the OPRC, was opportunistic study of medications. If a patient came in and was on a medication, if a patient came in on a medication that wasn't very well known in pregnancy, but they had to be on it for a reason, we would collect data on them opportunistically. We didn't change their management at all, but we got some data, and that's kind of what the registries are doing, and they're collecting data that way. So if you're on any of these medications, be a part of one of those registries, and that way you can contribute to the knowledge and help us get a little bit more information. All right. Or do you like the registries?
Yeah, I think the biggest one is over at Mass Gen. They're doing a ton of collecting data for pregnant women who are taking psychiatric medications, and it's been so helpful because we don't, you know, like I said, we don't have a lot of information on them, and so it's really helpful when women go and participate in those registries, just so that, you know, they're not trying to collect information on you necessarily. They're just trying to help get information in general on, you know, what's the safety risk of people being on these medications, or, you know, people getting off the medications. What were
their pregnancy outcomes? What happened with the infant? They'll collect all that data, and that's one good way to get some information. And then you mentioned 2 sites at the top of the discussion, and I'm going to fuse the 2. Don't worry, I'll fix it. About where to get information about medications, these types of medications in pregnancy. What were those?
Yes. The first one was womensmentalhealth.org. And the second one was mothertobaby.org. Yeah. And mothertobaby.org is probably the best one in terms of they have like a very easy to read fact sheet on medications that have research on them in pregnancy. And so if you can't find your medication listed in there, it's probably just because not a lot of research exists on it. Right. And in that case, I would recommend that you ask your doctor to call the provider consult line, the psychiatric consult line with Postpartum Support International, and get a second opinion on, hey, what should I do next?
Do you have time to answer a few questions?